When do we keep going with something hoping that there's going to be change?
If you're not making progress, the answer is always in the history and the physical exam.
If you are making a reduction in somebody's pain, or you're making even the smallest improvement in their quality of life, you are doing so much.
How do you even talk about treating and rehabilitating and changing the way a patient moves and operates unless you can quiet down the midbrain?
And then she says, I don't know what you're doing, but my leg pain is gone.
When you're treating abdominal anything, the first thing you do is scarring the vagus, because the vagus is a pain nerve in the abdomen, and you have to get it unstuck at various layers.
Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pettis.
This is the best I could do, was just pull over to a safe parking lot and join you this way.
Oh my gosh. And hope that you have enough cell reception to carry on.
I hope so. I'm close to a Starbucks. There's always good reception near Starbucks.
Oh, of course. That's the truth.
Yes. So hopefully everybody can hear me, and hopefully I'm not too patchy, but I will send the notes for today just in case, and you need to carry on without me. You will have all my ideas and questions.
The theme for today, because it's actually the first time it's happened in ever. Back-to-back patients. One came in, the first one came in saying, I have nerve pain down my legs, to my feet. And it's bad. It's noticeable in the daytime, better when I walk. And really bad when I sit reclined in bed watching TV every night. And then she has to take a hot bath, and then she uses ice, and then she does all this stuff. And I said, why don't you just not watch television from bed? But that didn't go anyplace. Anyway, I did an exam. She has 0 nerve pain, no nerve hyperesthesia, no straight 90 degrees, straight leg raise, no nerve pain, Braggart's, all of the nerve tests in the legs and feet, because all of her pain is from her waist down to her feet. And it just started from space. There was no thing. That was interesting. And it turned out that all of it was trigger points in muscles. And it started many years ago when she was on a tour bus, and you know how you climb up the stairs, you're on a flat thing, and then you step down into the aisle between the seats. She jammed her SI joint and the hip joint and the piriformis, and so she had enteric bursitis and trigger point pain that referred down her leg. Lyrica worked, which suggested it was nerve pain, but there was no. So I just worked on the muscles and the torn tendons of the bursa, and she left pain-free and went, wow. The patient right after her came in and said, I have muscle pain. My muscles are so sore. And her pain diagram was down both arms. And it was when she was using a keyboard a lot. But it was muscles. So the muscles in her legs hurt. And it was muscle pain. And because it was upper and lower body, and because she knew about things like that, she decided it was central, it was limbic. It was in
Okay.
her brain. So she's been doing brain retraining and relaxation exercises. And she has mold. They know about that. But she is in the care of a physician trained by Shoemaker who doesn't believe in treating mold. He diagnoses it, then you have to remediate the house, and then she's on cholestyramine as a binder, but no antifungals at all. And so her vagus is turned off, so she really is centrally sensitized. However, it turned out that when I ran 40 and 10 and 81 and 10, so her leg muscles were really tight, so that's why they hurt. And her arm pain, when I ran 40 and 396, she said, my muscles don't hurt. And so she was convinced it was all muscle and it was nerve. And the other one was convinced it was all nerve and it was muscle. Both of them had seen neurologists, both of them had seen psychologists, both of them had seen physical therapists up to their eyebrows.
Yep.
They had all the things, massage, acupuncture, all the things, except a sensory exam. And 40 and 10 and 81 and 10 and 124 and 77. So treat the spinal cord, relax the full body muscles. That was the muscle pain lady that was nerve pain.
Right.
And then the nerve pain lady that was all trigger point referral patterns, all trigger points. And whoever examined her didn't know about trigger point referral patterns. And so when I put my finger into her piriformis, which is, she said, it hurts whenever they're pressed on, which is characteristic of trigger points.
Yep.
And then I showed her remember I keep the charts on the walls. So then I showed her the piriformis diagram and she said, referral diagram, it's like down the leg and the bottom of my feet hurt. So the doctor said it was nerve pain. Did he use this little pokey thing on you? No. What's that for? It's to tell whether or not it's nerve pain. Anyway, so that was my story for the week. So what's on your list since you're in a Starbucks parking lot?
You know what? It's very funny. I'm not sure if I can join on Christmas. Next week I can't. I'm going to be in Europe. The weekend after that is Christmas Eve. So I wanted to do a little year-end roundup. What are some of our favorite things? But to piggyback on the nerve, connective tissue, muscle, cord, we had Dr. Jen Sosnowski on last week, and she was gracious enough to join as my guest because I wasn't sure I was going to be there. And sometimes it just works out that two people can just have a chat. She called me right before, what are we going to talk about? And I said, I'd like to talk about failures. And I don't think we talk about when do we keep going with something, hoping that there's going to be change. And Jen made a very good comment. We always want to see a reduction in pain. So even though sometimes we think we're not doing as much as we can with their health or their injury, if their pain is going down, we're doing something. And so as the year ends, I tend to get reflective, what went well, what didn't. I get excited about next year, what I'm going to do, the things that didn't go well, what am I going to cut out? And when I think about what brings me stress with work, I think about being a perfectionist, how fast I can close cases. So I wanted to make an overarching message today that if you are making a reduction in somebody's pain or you're making even the smallest improvement in their quality of life, you are doing so much. And I think as practitioners, we need to remember that because we talk about some pretty impressive things each week that we get to see and do. But there are also the small things that are equally as important. So that was one big message.
That's a big message. And for me, it's because I taught a core between Wednesday and Sunday.
Yeah.
And that was fun. And the take-home message, like we teach in the core how to do the treatments, how to treat nerve pain, how to treat what causes. Is it facets? Is it discs? Is it tendinopathies? Is it partial thickness tendon tears? Is it joint? All that. And then how to create a stable state. We teach how to treat, but the key to all of it is the physical exam. There is a slide that says the answer, if you're not making progress, the answer is always in the history and the physical exam. Yeah, the $19 pokey wheel. And there was at the seminar one practitioner slash who turned out to be a patient most of the time because she was so centrally sensitized that everything sent her into involuntary muscle jerking. And so I just had her and Dr. Osterberg off in the corner, and they treated for mold, and they treated for the brain injuries, and they treated for the early childhood abuse and all that stuff. But the thing she needed me to work on was the fact that she had sprained her lateral ankle ligament. That's the deltoid, right?
Yep.
It just avulsed it. And so she spent most of her childhood walking on the side of her foot, all of her childhood. It wasn't until 4 years ago that she had an orthopedic surgeon rebuild her foot, move tendons, do all this stuff. So we had to teach.
The connection's bad. I'm gonna go closer to the restaurant. So you keep talking and I'm just gonna get out of the car.
We're driving now.
No.
Oh no, you're walking. Stay in the car.
It is cold outside, but it's getting rainy, so I'll go closer to the Starbucks.
Okay.
It's the podcast on the move episode.
At least we're the Starbucks episode.
Yeah, I love it. At least we're here and we're doing this. This is the main thing.
There we go.
Let me see if I can get a very aesthetic background while I'm sitting here. How about that?
When I worked on her ankle, I could not have worked on her ankle nor leg unless somebody had worked on her brain for 3 days. Because anything we did peripherally, it was almost like a partial complex seizure. It was like that.
Wow.
And it was just really, it was interesting. So the pain at the bottom of her foot, I said, what is that? And it felt like a round tendon.
Okay.
And she said, oh, he had to take a tendon that was attached here and then stretch it around and attach it there. And the only thing that took the pain away in the bottom of her foot wasn't the nerve, wasn't the periosteum. It was torn and broken in the round tendon that he moved. And that was history. It's amazing.
I think we have to sometimes not overcomplicate things, right? So when we're talking about surgeries and interventions, just like how you walked us through it just there with what did he take apart? And then the story can sometimes grow to, and then what was that tissue's neighbor? One of my favorite stories, and so this is kind of part of my favorite, what were our favorite stories of all time? Never mind just this year, but I saw on the Facebook page, one of the attendees, I think it was from last year, the year before, from Arizona, who is an MD, came to the course. And you and I have totally stolen this from you, is the storytelling that happens when we teach. And yes, the slides are the slides, but a lot of times I'll break into, I have to tell you about this patient. And so a lot of times people who have come to the sports course know about phantom gallbladder story of a woman who came in with that lateral hip pain that referred down the lateral leg, followed the IT band into the knee, and PT, chiropractic, osteopathy, nothing had fixed it until I had found out that she had her gallbladder removed. I thought I was doing a good enough job doing some visceral work. But it wasn't until I started thinking about metallic toxins, if she was and it was her story that told me, oh, I love all your jewelry. I wish I could wear. I haven't been able to come close to metal since I was about 11 years old.
Oh my gosh.
And that was my face.
Yeah.
And so she was one of those patients that was so responsive to frequencies. The ones that are like, the minute you change it, they're like, oh, that feels great. Or they're like, no, that's not doing anything. So I was very fortunate that she was that person. And so the thought experiment was not to tell her I was running metallic toxins. It was just to think about it. Ran it on the gallbladder because that's where these clips are.
Staples.
And then she says, I don't know what you're doing, but my leg pain is gone. And I think that's when I left the room and I called you and I said, Carol, I think there's phantom gallbladder pain. And you were like, oh, honey, don't relax. Just blah, blah, blah. And you're like, what's next to it? And then I had to pull out Netter because I don't remember what's next to the gallbladder. Like, why would I care what's right next to the gallbladder?
Fair enough. I'm stuck on why would treating the right upper quadrant have anything to do with leg pain? I'm not sure. You know what, but I did such a good job treating everything else, but that was the one. And then we had figured out that we would get her 8 days of pain-free mobility. And then the pain would always come back on day 9 or 10. And then that's when the discussion happens of, okay, I don't want you to come back every 9 days. Buy a custom care. Treat yourself at least once a week. And that was in 2012. And she's been pain-free ever since. I love it.
The Facebook message was one of our doctors saying, I remembered Kim's story about this. And then I can't remember his specific, I think it might have been a shoulder injury that had some hardware in it or something. And that was what had resolved the pain. Just when I think I shouldn't tell stories, people listen to the stories and they're impactful.
People remember the stories better than they remember the slides.
Mm-hmm.
So if I'm blah, 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 blah about what's on the slide, then there are some slides that go with stories.
Yeah.
And they remember the stories, and I have to tell them to go back and look at the slides at the end. And, this core, I tidied up the nerve pain section, so I actually got to, Lori says, look at the gallbladder meridian. That makes sense. And Harry Van Gelder always treated the meridians. Unfortunately for me, he treated them with something that felt like a cattle prod, but that was the thing. But yes, the meridians are a thing. Where was I? I have no. The stories.
Yes.
I got to the visceral section before the noon practicum.
Have you ever done that before?
Ever. There have been some cores where we never get to the visceral stuff.
Right.
I was determined to get to the visceral stuff because we had a functional medicine endocrinologist, the only MD in the class.
Yeah.
And it's, okay, I want you to go back into private practice and use FSM because in 2027, you're going to be lecturing on what you just talked to me about, why women need to be on estrogen, progesterone, testosterone, what this is for, what that means. Everything you just said.
We need to hear.
Yes.
Yeah.
We'll see.
Great.
That was fun.
That's good. And every core that you teach, there's usually some sort of big story of a practitioner that you treated. So maybe there is something there that you want to share already.
The patient with early childhood abuse, mold, multiple brain injuries, but one of those keep on going sort of people.
Yeah.
I didn't do her pulse, but her voice was really high.
Yeah.
And so at first she responded really well. They increased secretions in the vagus and treating the midbrain. But then after things quieted down, after the vagus was on, increased secretions in the midbrain, in the vagus, increasing secretions in the vagus made her worse. And that's different.
Yes.
There was all the things. 20% of the class had vestibular injuries.
And do you think that's quite normal now? 20%?
It's
Is
flat out.
Yeah.
If there's a class of 20, there's going to be, actually there were 4. So that was about right. One of them didn't know she had a vestibular injury, and her score on the BIVSS was 52 over
Wow.
18. That was interesting.
Wow. Yeah.
So we know all sorts of good things, that we do all sorts of good things in a physical exam.
Yeah.
Leaf, should we take questions?
Yes, go ahead, because I'm having a, yes,
Okay.
you go ahead.
72-year-old female with sinus, eye, jaw, middle ear pressure pain that is sporadic. No. So orbital pain and pain in the eyeball makes me think of the C2-3 facet. Jaw pain, sinus pain makes me, that especially if it's sporadic, and middle ear pressure and pain. Did you do a vestibular screen? Anything that comes and goes? Did it come and go with the weather? Did it come and go with when it rains, when it doesn't rain? Having pressure in your middle ear without an infection is not normal. That tightens up. So the thing to remember about vestibular injuries is it tightens up the neck. All the neck muscles actually clear down to your low back. Sinus, it's like there's 4 different diagnoses there. Vestibular injury, TMJ, did she have braces? Eyeball could be a C2-3 facet, because if she has a vestibular injury, her neck muscles are tight and her facets get jammed. And sinus makes me think of mold.
Right.
And so the sporadic part makes me wonder about whether or not it's mold. And no, 20 is not the thing. Diagnosis is the thing. Sorry. CT to satisfy the ENT is betting on how, maybe I'm missing something. How do you diagnose a migraine with a CT scan?
I don't know.
I don't either. No change with the weather. Ear looks fine. The ear is going to look fine. You can't look in the ear to see if there is a vestibular. All of the symptoms come and go together. I don't know. It's okay not to know. It's
Right.
just one of those. I think I did a webinar a long time ago called Take It Apart.
Right.
So all the symptoms come and go together when? I don't know. Every day.
Right.
Here's you have a phone. Okay. On your phone, mark the day and the time when all of this starts.
Right.
So you can track what time of day. Is it the same time of day? Is it the same day of the week? What were you doing when that happened? What was the weather like when that happened? What were you eating when that happened? Sinuses are it doesn't go together in my head. So I don't know, Leaf.
Yeah.
And it's, by the way, everybody, it is okay not to know.
Thank you. Like that's part of when you don't have to, you're not expected to knock it out of the park every day, patient after patient. We want to. That's what makes us good practitioners, is because we care and because we listen and because we try. But hard cases are sometimes just hard cases.
And they usually find us when they've been whoops, there, you came back. They usually find us when they've been, you're muted.
Yeah, she is fast.
What happened?
You're just gonna have to take over.
There. Okay.
There you go. You got it.
Oh, I don't like this.
The other thing is, it's really important to know when it's outside your scope. One
Right.
of the things that it was unusual for me to get this aggravated at a practitioner. Like, I went all Dr. Mom on him. There's that slide in the visceral section about treating the immune system. And there's that line that says, don't run increased secretions in the immune system when there's an autoimmune disease. That's obvious. But then I said, when the patient has had a transplant, an organ transplant, do not treat the immune system at all. And there was I think it was an acupuncturist who started arguing with me about it. Wouldn't you want to improve, stabilize the immune system? No. Organ transplants are success are based on a very specific paradigm of the transplant physician. And they use immune suppressants, and they know what's supposed to happen when, because they have specific protocols. And he argued with me again, and he kept arguing. And it's, wait a minute. How many transplant patients have you seen or treated? None. I said, I'm not quite to double digits. Kidney, several. Heart, 2. Lung, 1. And
Yeah.
I haven't even gotten to liver transplants. I haven't seen one. But what I know is, if you change the function of the immune system, you run the risk of organ rejection.
Sure.
And that is a big deal.
Yeah.
So don't do it.
Yeah.
And and then one of the other people in the class said, just listen to her. Oh, okay.
Yeah. Who's teaching the class?
He really wanted to be able to treat the immune system, but clearly he hasn't dealt with enough organ transplant patients to know that especially different organs have different susceptibility to rejection.
Sure.
Kidney transplants seem to last the longest.
Yeah.
Both of the heart transplant patients I treated were 10 to 12 years into it, and still were fine.
Wow.
My friend that had a lung transplant, that didn't go well. Rejected the first one because it's so immune active.
Sure.
So
Makes
that's
sense.
anyways, it is okay for it to be outside your scope.
For sure. And that's why we have colleagues. That's why the FSM meetings are so great, because you get to meet colleagues that you can refer to and call and do peer-to-peer. There's so many times where I'm like, I don't know the answer to this. Let me phone a friend.
Yeah.
And even then, sometimes it's, you know what? You're going to go see that friend first and get things X, Y, and Z figured out, and then you'll come see me.
And sometimes you need to go back to your GP and get a referral to an X.
Yes.
Oh.
And sometimes there's that, you talk about the little bird on your shoulder. Sometimes there's a feeling that you don't know what that feeling is, but that feeling is saying something else is going on. I feel yucky about this. And until we know, it's okay to pause treatment.
We're not treated at all.
Right.
My massage therapist, when I was in practice, was a nurse from Russia. And in Russia, they use massage in the hospital as a therapeutic tool. So I sent her a patient who had trigger points in his rectus abdominis and low back pain. So I treated his low back pain, and I sent him to Dina, and she did the back, and then she did the front. And then he left, and she came over to me and said, Dr. Carroll, He has cancer in his abdomen. You are not to treat him. It's not good. Not
Wow.
the thick Georgian Russian accent.
Yeah.
Not right.
Wow.
But there was that.
There is that. So
little bird.
Yeah. And we have to be grateful for them. And it's like I said, again, you know your scope, you know your parameters, and that's okay.
And you know what a normal abdomen feels like. If you're curious, lay on your back in bed and feel your belly.
Yeah.
And when you feel a belly that just doesn't feel right, it's okay to say, how is everything? Have you done X, Y, or Z and all of that?
Yes. Yes. Do we have more questions? I can't see them.
Yeah, Louise can you refresh what are the cues that a condition is central in origin? She means centrally sensitized.
Right.
So centrally sensitized is
moving again.
Yeah, moving.
It's just getting loud outside.
It's getting hot outside?
Loud.
Loud. Oh, okay.
I wonder if this is good.
Centrally sensitive. Oh, we're indoors.
We're indoors now.
Cool. Centrally sensitized is when you treat them and instead of talking about the fact that part of your arm doesn't hurt, what they say is, my neck hurts. So they talk about what still hurts rather than what went away. The other part about centrally sensitized is they're sitting there talking to you and sitting in a chair, sitting upright, and they say their pain is an 8 or a 9. Okay, that's how much you mind the pain.
Right.
How much is it actually? The difference between the pain is actually a 5 or a 6, and I mind it as if it's an 8. Sometimes that is central sensitization.
Right.
Sometimes it's the tone of the voice is really high pitched.
Yeah.
Sure you don't want to go back outside?
Is it louder in here?
I don't know. Whoever the little kid is talking is just coming through great.
Okay, thanks. We'll figure this out. Okay, let's try this.
This is adorable.
I'm so sorry.
Fun. No, I'm not. This is great. I mean, we've done, how many of these have we done? 300?
No.
100
We're on 191.
191. We've done almost 200
episodes.
And this is the first
I'm on the move.
The first Starbucks Practicum podcast we've ever done.
But we're doing it.
There we go.
What do you always say? Something that you need it shows up, but it doesn't look like what you thought it was going to, or something like that. So
it must have been time.
Right. It was just, I had the best plans to get everything done today and squish one more patient in before I left, and it just cost me a little bit of traffic, but that's okay.
No, I was at the bank, and then I went and got gas, and then
it was time.
45, and it takes me exactly 15 minutes to get my maker on, my earrings in, and wondered, did I wear this shirt last time? I hope not, but
I don't think so.
Oh.
I'm pretty sure I've been a repeat offender a few times with my FSM polo shirt, but that's just coming from work attire.
Easy fix.
So one of my notes for today was, like I said, I like to talk about the cases that made history for the year. And we do a good job of, I think, of talking about that. And maybe I'll leave that in case my phone dies and you can talk about yours. But the top 5 A channels and our top 5 B channels of 2025. I'd like to see if there's something that's maybe new on your list that you've enjoyed. Let's start with the A channels first.
40, 13.
Those are like the tried and true go-to OGs.
The difference between 91 and 217. So 91 is hardening, calcium, sort of hardening mostly. And then 217 is calcium oxalate, which was in the published paper on breast density, but it's also the mineral that works on people that are 60 and over. And we had older practitioners in the class. I had to give out the 217 because 91 wasn't working. That's okay, fine.
Yeah.
And 81.
Yes.
And 49.
Yes.
Yeah. And
So,
the 970 is there as well, but I'm more inclined to treat the midbrain before I treat the emotions.
yes. Yeah. I will agree with you on all of those. I'm going to add 94 and 294. I've been playing a lot more with the trauma frequencies. I like them equally. I don't have a favorite. I don't discriminate between 94 and 294, but I've been using them quite a bit. Again, it just fits the model. If we think about how did we get in this situation? How did the scarring happen? Something tore. How did the tearing happen? There was trauma. So I feel like that is a very helpful frequency to use in those figuring out stages when you don't really know how we got here. And
the story that goes with 290 trauma.
Yes.
So we do trauma paralysis, allergy reaction.
Yes.
Secretion of vitality, because that's Harry's sequence.
Yes.
And then there was that case, and you were there when I was doing the treating, where the pelvic floor muscles were just like guitar strings, and I treated it, treat the nerve, treat the muscle, and then the patient kept talking about my uterus never had time to recover. My uterus never had time to recover.
Yes.
And it's recover from what? So I was going to run the trauma sequence just as a drive-by, and I got to trauma in the uterus.
Yeah.
And the whole pelvic floor just went to pudding.
Thank you.
Yeah. Thank you. And then they love the end of the story where their third child was born 9 months and 4 days later.
Yes. Trauma over.
Yes.
But yeah, like we've seen it in action, and I do enjoy that frequency quite a bit. So I was adding 294 and 94, and I will agree with you on 124 and 13, 49 vitality. They're just all
124 and 77 has turned into something magic.
Yes. It is a magical little pairing, isn't it?
It is.
Okay. So what about the B channels? Do you have any new tissues that have made it on your radar, maybe, or you have a new respect for, maybe?
Probably the 46, and that's because of you. It's when you strain a muscle and the muscle is actually injured.
Yeah.
Then it's 294 or trauma and torn and broken in the sarcomere.
Yeah.
And so that one is one I have never used because it didn't make any sense to me that 45 would be the nervous system as a whole.
Yeah.
46 would be the muscle as a whole. 47 is the that whole sequence just was like, whatever. And then, so 46 is still the only one I use.
Right.
Out of that sequence of specific when it comes to the nervous system.
For sure. For sure. I am still pondering if it is sarcomere, sarcoplasm, or sarcolemma. And so in the sports advance, the slide says 46, the sarco something.
Something.
Because I think it would be extremely hard to differentiate between a sarcomere, the sarcoplasm, and the sarcolemma with frequency. But it is like so many things with frequency, it adapts to what you need it to adapt to. So when I was playing around with post-exertional hypertrophy, which is that swelling or that pump that you get after you lift weights, or for my hockey players after they skate, their quads and their thighs and their upper legs are huge. So this was a great experiment to just measure girth and then running inflammation in the and this would be, in my opinion, sarcoplasm, because the sarcomere doesn't need to go down, but it's the plasm, it's the byproduct that's surrounding the myofibrils that gets full. And 40 and 46 was what helped decrease the size of the leg post-exertional. So that's why I started thinking maybe it's the sarcoplasm or the sarcolemma, and I'm okay with not knowing.
And that's what we end up with is you have to be okay with a certain amount of, I have no idea what we're doing. There's every class, it's, you guys understand that we don't actually know exactly what we're doing. The data suggests that what we're doing is changing cell signaling.
Yeah.
That's the only way that the cytokine data and the mouse research would have.
Did we get in their question?
Yeah, that's a good one. Would have happened. You can't reduce everything that comes out of a spinal cord neuron when it's inflamed unless you're treating the neuron. Diana Cross with that lecture, and I'm really sad I am not flying her in from Australia, mostly because I feel bad about we really don't have room to put anybody else on the afternoon. By the way, speaking of the high spot of the year, we have 4 published papers.
Let's go.
This year. That's scleroderma, Ehlers-Danlos, and Maria Lamont published a paper on something. And then Louise did his paper, presented his paper on osteoarthritis last year. That's already been published. This year, apparently, he's treated Guillain-Barré, and he's going to be publishing that. So he's got 15 minutes to talk about how he's coming from India.
Great.
Yeah, there's
Yay. So that was an absolutely huge highlight for 2025. So let's go back to our B channels. What did we?
B channels.
We talked about 46.
I love treating the brain.
I know you're our little neuro love, and I appreciate you loving it because and then I appreciate talking to you every week because it makes me think of it more than I ever possibly would have in a musculoskeletal practice such as mine. But you can't do one without the other.
And you are the reason that it is now in the core in the musculoskeletal section.
Yeah, it needs to be.
So you get to tell a story about the midbrain. It's in pain. So the sensory cortex says, I want to pick up this plate out of the cupboard. And that signal, I want to, it initiates movement, goes to the hippocampus and the thalamus in the midbrain. And they say, yeah, but that hurts. And no. And then the signal goes down to the cerebellum and says, don't worry about it. I got it. I can do this. And it inhibits this and it operates that. And you have completely abnormal mechanics.
Right.
But it gets the job done.
Right.
So how do you even talk about treating and rehabilitating and changing the way a patient moves and operates unless you can quiet down the midbrain? I think you're the one that says, give it a binky and a blanket and tell it to let it quiet, get it out of the way.
Yeah.
And so all of that is now in the core in an entirely different place. So it was really fun.
I couldn't have done it without being at that advanced. And I can't remember how long ago it was. It was the very first advance that I went to. And I want to say the presentation was on stroke rehabilitation. And that was when we started talking more about the connection and helping the cerebellum coordinate the movement and find it. This has to happen all the time. And then that was our infamous swimmer that we worked on together. When we were getting accuracy at 94, 93% all the time, I was like, okay, this is something. So yes, absolutely. We need to talk a bit more about the brain. I'm going to add for my tissue types, Adipose 97.
Yes.
It's been a big year for me utilizing that more. Adipose is everywhere. It's like that fascial matrix. It's all there. So when you get stuck, I always think, well, there's got to be adipose somewhere. Treat it using 3, yes. And then also using it with the omentum. Diaphragm will be my next one that I've been playing around with a little bit more. And then if you're going to treat the diaphragm and the vagus, you have to get rid of the omentum on top of that first. So those were my bigger love affairs this year.
I would go with that. And then every single core, it's ureter and psoas, kidney and QLs, and they both weave into the diaphragm. Psoas from the front, QLs from the back.
Yeah.
And when you press on the ribs, the lower ribs, they don't move.
Yeah.
And you say to the patient, those should move. And so the class, that's one that I actually demo now. Somebody with low back pain, it's never not the psoas, and it's
too many negatives.
Yeah, too negatives. Never not the ureter and the psoas, scarring in the kidneys, sclerosis in the fat pad. And it's just become, we got it. I finally, thanks to Kevin, got the pictures that I can change on the slide so we can actually show where to put your hand, because it's not apparently not intuitively obvious. So that was, the diaphragm. And then the other one, the pleura.
Ooh, the pleura.
Oh, it's so you get the lower ribs to move, and all of a sudden you notice that the upper ribs
don't move. Yes.
And it's, do you ever have pneumonia? No. Asthma? No. Live someplace next to forest fires? Oh yeah, there's a big fire next, blah blah blah. Yeah. What irritates the pleura? And after inflammation comes scar tissue. So scarring and hardening in the pleura, and rock the ribs, and then teach the patient how to breathe.
Yes.
What's more fun than that?
I don't know. The rib movement, it's amazing how people are used to not having thoracic mobility. They just think they should not have it due to, I don't know. I'm not sure if somebody told them once upon a time that the thoracic spine shouldn't move, or you shouldn't have as much. Like, we should have rotation, side bending, flexion and extension in the thoracic spine. And like you said, teaching somebody to move their ribs in a way that they never have, it's just like any other patterning. It's getting somebody to do a deeper squat or extend their elbow. Like, it's the same principle of having to walk them through it. And breath should be so obvious and easy, but it's not. You can say, you can breathe deeper, you can move these ribs even more, and the look on their face is just...
I cheat because I have the patient put their hand on their belly.
Yeah.
It's like you need to connect you need to connect their sensory cortex with their hand. So put this hand on your belly.
Yeah.
And this hand on your ribs.
Yeah.
And I want you to keep your belly flat and inhale from here. Now, people that have had asthma are used to breathing with their scalenes.
Yeah.
Up here.
Yeah.
And down on their belly. So they go ahead and breathe. And when their belly hand goes up, nope, that stays down.
Yeah.
And you have to convince the brain that the ribs can expand, and you have to feel for adhesions between the nerves and the ribs.
Yes.
And it's I don't know, it's how many pieces are there in a puzzle?
Right. Yeah. As big as that puzzle that you have has.
Yeah.
Okay. Intercostal pain spasm. I had 2 of them this week. One resolved, one did not.
Yeah. Okay.
One was just like it's when you get that stitch sometimes after you run, or sometimes you get it up higher. Women will typically get it underneath the bra line. It can be scary. People think it's their heart, and you're like, it's not your heart. But if you have heart problems, go get this checked out. Don't just believe me. And I had one that didn't resolve, and I tried absolutely everything. And
sensory exam was normal.
Yeah,
little pinwheel thing.
Yep.
And
did I do it?
Yeah, there's that.
Yeah.
Yeah, there's the one that I love telling the policeman's story with the drunk combative suspect. And he'd been on light duty for 2 years. And if you've ever put a street cop behind a desk for 2 years,
Yeah, it's not good.
Not happy.
Yeah.
And his diagnosis was still sprain strain thoracic spine, because he grabbed the bad guy and they both fell backwards together.
Yeah.
The bad guy landed on him.
Yeah.
So I had him take his shirt off. He said, nobody's ever had me take my shirt off. Excuse me? So I did the pinwheel, and sure enough, one nerve, and I think it was like T6 or 7, was purple. So he had the sympathetic part of the nerve was stretched. And then the one above in the thoracic spine, there's a lot of inner neurons. It's never one level. It's two above, one or two above, and one or two below. Anyway, and we treated him for a nerve traction injury, and then treated the sympathetics to not make it not be purple, and then did scarring in the nerve. So if you look at the ribs, nerve, artery, I ignore the poor little vein, and at some point that's going to catch up with me. Osteum.
Yeah.
And the intercostal muscles go this way and that way. There's two layers.
Yeah.
And that can be torn and broken in the connective tissue, because it's a little skinny muscle with a connective tissue up and down.
Yeah.
And I don't think there's any adipose in that particular space. And I had one patient, couldn't keep him out of pain. It was T2.
Yeah.
And his mechanism of injury was he leaned over, he's 6'5". He leaned over and he picked up a couch, like literally flexed, and then lifted. And I sent him back to Kaiser, because Kaiser sent him to me for this, I swear to God, shoulder pain. And he put his hand here. Okay. So they did an MRI of his thoracic spine, and sure enough, there was a T2 disc bulge.
Right.
Or T3. Nobody's going to do surgery on a T2 or T3 disc bulge. So it's not going to get better if it's a disc bulge.
Yeah. Yeah.
So,
and there's that too. Did we get another question? I just want to make sure that we're finishing these up before the time is out. I just get a little notification that there's something, just some sort of activity.
Constipation in early, thank you, Suzanne. You always ask the best questions. And you seem to see a lot of Ehlers-Danlos patients. Bowel resection, oh dear God.
So I might let you answer this, because my battery is about to go. So I will, and we only have 3 minutes. So I'll let you.
2 minutes.
The Starbucks episode is about to come to a close, but I'll let you finish that, because it sounds like a you thing anyways. But happy holidays to everybody. Don't forget to register for the advanced and everything in Arizona before the early bird pricing evaporates at the end of the year. And think about all the great things that you did this year and all the great things we're going to do next year. So there's all of that. And thanks for putting up with me at Starbucks.
I love it. It was just perfect.
Christmas isn't Christmas without some sort of Starbucks drink.
But it's flexibility, which is an ongoing theme in FSM, is don't get attached to your idea about things.
I would have loved it on the podcast with my comfortable microphone, but you know what? Being adaptable, it was the lesson for 2025. That's for sure.
It works.
All right. I'll let you finish that. Bye, everybody.
Bye. Merry Christmas.
Merry Christmas.
Okay. Constipation in Ehlers-Danlos who had a bowel resection. No, not muscle at all. Bowel resection would be scarring in the vagus, actually, because the vagus, Suzanne, the vagus makes the bowel move. Scarring in the large bowel. Where was the bowel resection done? It was probably done for a knot. What do you call it? An ischemic bowel, where it just gets tangled up and then it cuts off the blood supply, and that doesn't go well. And it's not the muscle. The bowel, you have what bowel part did they resection? So is it descending? Is it sigmoid? Is it ascending? Where did they do it? And then the first thing I'd go after is scarring in the vagus. And that was the other thing. I changed the course slides again, and Kevin still talks to me, which is really good. And the thing that I changed the most often was when you're treating abdominal anything, the first thing you do is scarring the vagus, because the vagus is a pain nerve in the abdomen, and you have to get it unstuck at various layers. So scarring in the vagus first, and then you get a certain amount of softening, and then you do sclerosis in the omentum, and then you get down to the serious business of whatever part of the GI tract is scarred to whatever part it shouldn't be scarred to. And then at each level throughout the abdomen, you're going to run into scarring in the vagus. That's Ehlers-Danlos patients have vagal difficulty anyway, so they are prone to slow motility in the gut because the vagus doesn't work well, because they're always, every time they stand up after lunch, they have a traction injury in the vagus. And so I'd still treat her for EDS, and actually you'd have to treat her for 124 and 77 and 40 and 10 from neck to feet, while you're using a precision care on her belly to treat scarring in the vagus and then scarring in different gut parts that might be scarred to each other when they did the bowel resection. Speaking of gallbladder meridian, remember that slide for the acupuncture meridians, where the organ associated with that meridian is what you use to treat that meridian, whether it's damp or tinny or congested or whatever. This year, and I forgot to tell Kim, but I'll tell her later, this year I started using balancing the meridians. So we're used to 35 and 102 to balance the crown center, and 35 and 33 to balance the heart center, 35 and 200 to balance the solar plexus. And then this year, when we had a larger group of acupuncturists, especially those that do pulse diagnosis, found out that there are times when, if a meridian is deficient enough, you can do 321, you can do 50, but if you do 321, which is just reboot, control alt delete in that meridian, if you go to 49 right away, the meridian clamps down again. It's just too soon. It's not ready for it. But you can do 35 or balancing the meridians, and that always worked, at least in that class. And we don't always have acupuncturists that can do pulse diagnosis, but it's really fun to be able to do that. So Lori and the other acupuncturists that are listening, consider that as another favorite channel A. And it's 403. I think I'm going to be here next week, right?
Next week.
So I'll be here by myself next week, and Kim will be off in Europe, I guess. The week after that is Christmas Eve. And I don't know if any of you want to come to a podcast on Christmas Eve. I guess you can ask me or tell us next week. And have a great week. Do good things. Change lives, change the world. The usual stuff. Have a good one. Bye.
The Frequency-Specific Microcurrent podcast has been produced by Frequency-Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.